Hello, everyone, and welcome back to the Gambia Symposium. My name is Michelle James, and I'm an assistant professor here at Stanford, jointly appointed in the departments of radiology and neurology. My co-moderator today is Dr. Bryan Smith, who is an associate professor of biomedical engineering at Michigan State University. Bryan and I are actually really fortunate that we were able to do our postdocs together in Sam's lab many, many years ago, an experience that we'll never forget and we'll always be very grateful for. It's my honor to introduce and co-moderate this session that's focused on molecular imaging. As you've already been hearing a lot about this morning, Sam was really a true leader and one of the key founding fathers of molecular imaging. Not only did Sam make impactful contributions in the areas of PET imaging, which is a core modality in molecular imaging, but his laboratory also pioneered many other molecular imaging approaches using ultrasound, photoacoustics, intravital microscopy, Raman spectroscopy. Of note, his PET reporter gene imaging work that many of you would have read about, work published in Science Translational Medicine, among other high-impact journals, that work really showed that it was possible to track engineered CAR T immunotherapy in glioma patients using FHBG, for example. This is just one of the many translational impacts that Sam's molecular imaging work has had on the field. When Bryan and I were preparing for this session on Friday, we kept coming back to the fact that Sam really had this unique way of running his lab meetings to talk to us about molecular imaging. He would share personal stories about the clinic, new ideas or questions he was interested in, problems he wanted to solve. He would engage us all. He would quiz us when we least expected it, which was always fun. And he was just genuinely excited and completely invested in every single project and in mentoring us through those projects. He did everything with childlike enthusiasm, and he had a sparkle in his eye when he would talk. And so in this session, we'll be hearing a lot about the molecular imaging work that Sam was a part of or inspired, and we'll be hearing from actually 4 superstars in this field, and who all really knew Sam well. They worked closely with him over the years. And to kick things off, it's actually my great pleasure to introduce to you Dr. Anna Wu. She's a professor and chair in the Department of Immunology and Theranostics. She's a co-director of the Center of Theranostic Studies at the City of Hope. She's also a professor in the Department of Radiation Oncology at the City of Hope National Medical Center. Additionally, she holds the title of research professor at the Department of Molecular and Medical Pharmacology at the School of Medicine at UCLA, which is where she previously served as professor and vice chair. Anna is the past president of the World Molecular Imaging Society, and she's going to be sharing with us today all about different aspects of her work and her relationship with Sam. Thank you, Anna.
Thank you so much, Michelle, for that introduction. It is really such an honor and privilege to be part of this session and to be able to share with you my interactions with Sam early on and how he's influenced our research. So I'd like to thank Joe Wu and the co-organizers for the opportunity to participate, and Aruna for her support throughout. And before I begin, I do need to disclose that I'm a founder, board member, and consultant to ImagineAb. And as many of you know, one of Sam's favorite questions or thoughts, or the way he'd kick things off, would be the question, what if? So this is my journey in what if. Now, Sam and I only overlap by 2 years, and yet he had a profound impact on the research that I do and the work that our group does. He was an assistant professor at UCLA. And actually, I was introduced to Sam by Mike Phelps, who invited me to do a sabbatical at UCLA and told me I had to meet this brilliant young faculty member who shared some potential overlapping interests. So I was absolutely thrilled to be able to spend a year at UCLA as a member of the Gambier lab. I was working at City of Hope at the time, but this was my sabbatical year. Sam's formal training, as you heard, was in biomathematics, which meant when it came to biology, he had no preconceived notions. And you've already seen Sam's earlier statement about he was drawn to nuclear medicine because he wanted to image biochemistry. And for us, he posed the question, what if we could directly image gene expression in vivo? This was the subject of my sabbatical. And he met directly in vivo. So along with Xiaotrine Sun, shown here, who was my able assistant during that year, we spent a lot of time trying to figure out whether we could use antisense oligonucleotides and radiolabel them and use them to directly image HER2 messenger RNA. Needless to say, that project didn't get very far, but what I brought to the table was the concept of imaging proteins, which are one of the ultimate expressions of gene expression, the ultimate results of gene expression through the use of engineered antibodies for PET. So that was my sabbatical year. Then I went back to City of Hope, but not much later, I was able to spend another year with Sam because by 2002, he had been advanced to full professor in the Department of Molecular Medical Pharmacology at UCLA. He was also the director of the Crump Institute and had several faculty slots into which he could recruit. And so I had the privilege of being his first faculty recruit, but I also was his last faculty recruit because, as you know, Sam relocated to Stanford in the summer of 2003. And this is a picture of the farewell trawling trip that we took, a joint lab meeting with my lab and Sam's, where we went out to sea. And Sam, of course, was never one to waste a good party. There was a what if question. The real mission was, what if we could find a really red luciferase? So we went out in the middle of the night between Catalina Island and Long Beach and went trawling and pulled up all sorts of interesting creatures from way below the ocean's surface and managed to isolate three members of the black dragonfish, three specimens to take back to the lab eventually to try to clone out their very red luciferases. So that was my second year with Sam. And then over the subsequent years, even though he was at Stanford and I was still at UCLA, we continued to ask what if. And wherever I could, I tried to fill in with my expertise, which was antibodies and protein engineering. So we looked at engineered antibody fragments and PET reporter genes based on antibodies, fusion reporter genes, targeting nanoparticles such as quantum dots using antibodies, redshifted luciferases, et cetera. Multiplex modality imaging, and ultimately imaging immune responses. And here's just a photo from 2007. I was actually very happy for 10 years to be part of the Stanford Center for Cancer Nanotechnology Excellence. But there also was another question that united Sam and I over the years, and not just the what if, but we never were very far from the why. And of course, the why was about patients and people. Why were we doing what we were doing? Because we wanted to change people's lives, help people. And he also helped me understand that commercialization actually is part of translation. It's the ultimate step in translation when whatever your ideas are, they can be turned into products that can actually be out there and be available to anyone. And so with his encouragement, I co-founded ImagineAb in 2007, and Sam was an original member of our scientific advisory board and helped us over many years with how to approach antibody-based molecular imaging. So here he is at an SAB meeting with Steve Larson and Dan Shohat. Okay, so let's go back to the what if. What did we really try to do and accomplish, starting with my sabbatical year? What if we could directly image protein expression using antibodies? And here we faced a big challenge back then because most of the positron emission tomography that was being done used short-lived radionuclides, C11, O15, and fluorine-18, which, as you can see, has a half-life, a physical half-life of 109 minutes. Whereas I wanted to combine PET with antibodies, but intact antibodies have very leisurely kinetics in the body with half-lives of 1 to 3 weeks in the circulation. So by the time your antibody would get where it's going, if you had labeled it with fluorine-18, the radioactivity would be long gone. So this required serious progress on both sides of the equation of antibodies and antimatter. So my lab focused on what's on the left. We re-engineered antibodies to have properties ideal for delivering radionuclides into patients. We started with intact antibodies, which, as shown here, can give you very nice uptake into your target tissues, but have very slow blood clearance. And even after several days, you still have significant radioactivity circulating in the blood. So we engineered these antibody fragments, such as minibodies and diabodies, which are bivalent, and they retain the exquisite specificity and affinity of the parent antibody. But because of their smaller size and the lack of an Fc region, they target and clear much more quickly. They still reach significant uptake levels in our target tissues, but as you can see, the blood clearance curves are much faster. And in fact, within 24 hours for the minibody, or even just a few hours for the diabody, we have no background left in the circulation and have the opportunity to do our imaging much earlier. We were also supported by tremendous advances in nuclear chemistry and production of what were at that time exotic positron-emitting radionuclides, including copper-64 with a 12.7-hour half-life, iodine-124 and zirconium-89 with 4 and 3-day half-lives, respectively. So this is indeed what I did during my sabbatical year. I put together the mini-body and micro-PET. And here is the agent. It was a copper-64 labeled mini-body. So we had an assist from Deb McCarthy and Mike Welch from WashU, in addition to our teams at UCLA and City of Hope. And it retained specificity for CEA. And we were able to use Simon Cherry's micro-PET, shown here, hand-built, designed and built by his postdocs and students. And at the time, it really was the only micro-PET on the planet. And we had the privilege of using it. So on the right are those early results showing you a micro-PET image in a mouse with a positive tumor, CA positive tumor one shoulder and negative tumor on the other, showing that we could image within 5 hours after injecting this radio tracer, and then digital whole body autoradiography to confirm that that signal that we saw in the micro-PET was indeed due to the fact that that's exactly where the protein had gone. And over the years, we expanded this into really a broader approach towards molecular imaging of protein expression, with an asterisk, of course, because we are limited to targets on the cell surface. But by using immuno-PET with antibody, engineered antibody fragments, shown here, examples using diabodies and mini-bodies, we were able to show that taking parental antibodies with a variety of specificities to, in this case, interesting cell surface targets on tumors, we could reformat them into these fragments, label them with a variety of different positron-emitting radionuclides, and have an immuno-PET tracer that was capable of either next day or even same-day imaging. So what's next? What if? What if we could directly image immune responses in vivo? This question became more pressing as we saw the advances that were occurring in the field of cancer immunotherapy, which is now really the fourth pillar of cancer treatment, along with radiation, surgery, and chemotherapy. And so many different approaches have been pursued over the years, but have are finally coming to fruition. And some examples include checkpoint inhibitor therapy with antibodies such as nivolumab, pembrolizumab, atezolizumab, bispecific antibodies that recruit therapeutic immune cells to tumors directly, or CAR T cells where the therapeutic cells themselves are genetically engineered so they can directly identify and home in on target tumor cells. And vaccines, cancer vaccines, such as Provenge or GVAX, in development to provoke a new immune response in the patient's tumor so that the patient's immune system can then recognize tumors and defeat them. An important aspect of many immunotherapies is they all converge on this one specific effector cell, the CD8 positive cytotoxic T lymphocyte, as the actual active ingredient. So that raised the question of, is this something that we could look at in terms of imaging immune responses in vivo? And the reason we were inspired to pursue this was because there still remained diagnostic challenges in immuno-oncology. We have wonderful anatomic methods of imaging, CT and MRI. We also have FDG PET, which has been an invaluable tool for diagnosing and monitoring cancers. But the challenge here is that immune responses often mimic tumor growth in terms of an increase in size of the tumor or continued activity with FDG PET. And tumors and immune responses can be heterogeneous throughout the body. We also have wonderful methodologies for really deeply profiling biopsies and blood samples, but those are limited by sampling limitations. So we asked, can we directly image CD8 T cell responses? And our approach, being antibody engineers, was to start with mouse or human-specific anti-CD8 antibodies, reformat them into fragments, conjugate them with desferoxamine and radiolabeled zirconium-89 for immuno-PET. So on the left is one example of some of the preclinical work that we did using a mouse-specific anti-CD8 cis diabody radiolabeled with zirconium. And these are syngeneic mice bearing CT26 tumors treated with anti-PD-L1 checkpoint inhibitor antibodies. And much like humans, some respond and some don't. First of all, you'll see in the images the kidneys, because that's the organ of clearance, but you'll also see spleen, and you'll see hints of lymph nodes, and you'll see the CD8 T cells in the tumor. And in the non-responder, you can see they're not really in the tumor. That tumor is very large and has a cold center. But in responding mice, in responding tumors, we can see that there are CD8 T cells through and through. So in order to be able to take, Progenab developed the human-specific engineered antibody fragment, crefmiralimab. It was radio-labeled, again, with zirconium-89 through desferoxamine. It retains sub-nanomolar affinity for human CD8. Extensive studies were done in vitro and in vivo to confirm that this fragment really is biologically inert, because we do not want to perturb the very immune systems that we are trying to image. And this is just one example of a preclinical imaging study in a humanized mouse where adult NSG mice are reconstituted with human peripheral blood mononuclear cells. And what happens is about a week after injection of those PBMCs, the human immune system is reconstituted in the mouse. We can image it here. You see this strong activity in the spleen, also in the liver, which is partly due to clearance because this is a larger fragment and it clears via the liver, but there also is hematopoiesis in the liver. Now, if you wait a few additional weeks, we also see a haze appearing in the lungs. And this is one of the tissues that's attacked in GVHD in this model. We can pick it up in the PET scan, as you can see here. And when those tissues are removed and stained for those human CD8 T cells, there they are in the lung where they shouldn't be. So what if we could image CD8 T cells in people? So this is a snapshot of the phase 1 study, which is complete. It was conducted in 15 patients at Memorial Sloan Kettering Penn and Honor Health. Two overall goals. One was to establish what was the optimal protein dose to image with this agent. And the other was to figure out what is the optimal time point after injection that we could visualize the immune system. And here are the first 15 patients shown below. And in summary, the results show no adverse events, rapid blood clearance as we expected. These are all 24-hour images, and you can see the blood pool activity is basically gone. And what we do see is uptake in those T cell rich tissues that should have CD8 T cells in normal people. We see spleens, we see lymph nodes, and we see bone marrow in these patients with low background in normal organs. And importantly, in about 2/3 of these patients, we're able to see signal. Here is the FDG PET of a patient with a melanoma with a small lesion in the shoulder. The CD8 immunopet showed co-localization of that CD8 signal, and subsequent biopsy confirmed that there were CD8 T cells present in that lesion. And so the next question, yet another leap, what if we could image response to immunotherapy in people? So this is the phase 2 study that is ongoing. And as you can see, it involves patients who are planned to go on to standard of care checkpoint inhibitor treatment. They are first given a pre-treatment CD8 immunopet scan and biopsy. They start therapy, and a month later, there's an early on-treatment PET scan, CD8 immunopet scan, and biopsy. And here's an example of one of those patients, again, a melanoma patient. Prior to treatment, here's the FDG PET scan, and there is a lesion in the calf that is very FDG avid. And here is the pre-treatment CD8 immunopet, and you can see a faint signal at the same location, and you can see there's heterogeneous CD8 signal, including regions that are quite cold. The patient started immunotherapy. A month later, returned for a CD8 immunopet, and now we can see a very strong signal in the PET. And then 4 months later, a follow-up standard FDG PET scan showed reduction of the FDG signal and shrinkage of the tumor. So we think that, yes, we can image responses to immunotherapy in patients. What's next? We'll continue to explore the utility of CD8 immunopet for response to therapy, for patient selection, not patient selection, but really selecting the right immunotherapy for patients to optimize combinations. Perhaps as an early warning of side effects, we're certainly going to be looking closely at patients to see if we're seeing CD8 T cells where they shouldn't be. But we in the field are taking a much broader look, and this is many labs worldwide, Stanford, elsewhere, looking in general at different immune cell subsets that play key roles in immune responses and biomarkers of their activity, and asking questions, can we identify an immunosuppressed versus an activated microenvironment and use that to guide our development of therapies? And this, of course, has implications beyond oncology: infection, inflammation, autoimmunity, cardiovascular disease, neuroinflammation, diabetes. There's so many potential ways that being able to image the immune system in action could be very, very useful. But going back to really some broader questions that Sam posed. What if we could image in color? This has always been very central to him and to me, because we know biology is complex and no one tracer is going to answer every question. So we've got to find better ways to do multiplex imaging and capture this complexity. And to bring it to patients, we need faster and cheaper molecular imaging. And of course, in the end, it's about not just seeing disease, but treating it. And that's why I'm also very committed to growing our theranostics program. So finally, I want to say thank you, Sam, um, for your leadership, your vision, your inspiration, your friendship, and your support. Even though we only overlapped for 2 years, we've been very close personally and scientifically. And also, thank you, Sam, for all the wonderful people that you introduced me to over the years. These are just some snapshots from times at UCLA, but also at the bottom, I've added in some of the many colleagues that I've met and collaborate with and just enjoy spending time with at Stanford. So it must be 5 o'clock somewhere, but here's a toast to Sam Gambier and to the rest of you out there. We still have a lot of work to do. Thank you.
Thank you so much, Anna. That was wonderful. And I did want to mention just really briefly that in addition to all of these accomplishments you just heard Anna talk about in ImmunoPET, she's really someone that makes time for students and time to help and lift up and encourage the next generation, just something I know was the most important thing to Sam. So thank you, Anna. And now I just wanted to, it's my great honor to introduce Dr. Simon Cherry, who's the distinguished professor in the departments of biomedical engineering and radiology at UC Davis. Dr. Cherry's research interests really center around biomedical imaging, and in particular, the development and application of molecular imaging systems. His major accomplishments have been in developing systems for PET, in particular, the invention of micro-PET technology that has been widely adopted in academia and industry. He's also the co-leader of the Explorer Consortium, which has developed the world's first total body PET scanner, which I know is something that Sam was particularly excited about. So Dr. Cherry, please take it away.
Thank you, Michelle. It's just a tremendous honor to be invited to speak at this symposium today. Of course, it shouldn't be happening like this. Sam should be with us. If he were, he'd be giving us a keynote address. He'd be articulating his vision as clearly as always for the future of early disease detection and the role of imaging and other technologies in stratifying and managing patients. He would be out front lighting the path ahead for all of us and giving us much to think about. And you never came away from a talk that Sam gave without learning something, and more importantly, without being inspired. And although Sam's not with us today, he's shone a bright and lasting light over our field that's going to serve to guide us for many years to come. So I first met Sam just as he was completing his PhD, actually. I moved to UCLA in 1990, and Sam was just finishing up his PhD in biomathematics at that time. And, I went to UCLA primarily because of the senior faculty who were there at the time, and particularly Mike Phelps, who you'll be hearing from next. But one of the reasons I stayed at UCLA for so long was not just because of the fabulous senior faculty, but also because of a bunch of junior scientists who were just amazing to work with. And of course, Sam was prime amongst that group. And probably the best times we had were in the Crump Institute. You've already seen this picture that Anna showed on the left as well. But it was an amazing scientific playground. And for me as a physicist, it really opened my eyes to the broader world of biology and medicine. So I got to collaborate with Sam on quite a range of different projects. The paper on the left was the very first thing we published together, which was on blood sampling in mice to go along with doing micro-PET studies. Sam always had an eye for quantification throughout his career. That was always very important. But we got to work on a range of things together, as you can see here. But perhaps it's the paper up top right that influenced my career the most. This was a very multidisciplinary project, inspired by some great people at UCLA, Mike and Harvey Hirschman. But really, Sam was the one that sort of grasped this and ran with it and brought everybody together. And I sat in meetings at the beginning not having a clue what was going on as a physicist, and sent me scrambling to textbooks to try and understand what gene expression was, what reporter genes were. And it really made me appreciate that if I was going to be an imaging scientist, I had to not just focus on the physics, but I had to embrace the biology as well. And that's a lesson that stayed with me throughout the rest of my career. So, Sam's scientific contributions are just legendary, of course. Here's just a word cloud showing, some of the words that pop up if you search through all of Sam's publications. His knowledge was broad across many different areas of the field. He was equally at home talking about the physics and engineering aspects, the chemistry aspects, as he was talking about the biology and the medicine. But I want to close this brief remembrance of Sam by talking about Sam the man, because one of the things that always impressed me about Sam was he always had time for others, even with all the difficult things he was dealing with in his own personal life and his very busy professional life. Whenever I saw him, he'd always ask me about my family, what my kids were doing. And when he was talking to you, you always felt you had his full attention, despite how busy he was. He was there at that moment for you and for you alone. And that is perhaps the quality that I most admired about Sam. So today, the project I want to talk to you about is one that I think is consistent with Sam's vision for the future of medicine. And that is developing a PET scanner that can view the entire human body at once. This is a project that I've been working on for the last 16 years now with my close friend and colleague here at UC Davis, Ramzi Badawi. So the motivation for this project comes about from thinking about how we collect our signal in conventional PET scans. And so while we have this elegant radio tracer method, we have these very sensitive radio tracers and specific radio tracers that we inject systemically into the body. They're emitting signal from the entire body. Our instruments are really not well suited for picking up that signal. We only cover a small fraction of the human body in any one at any one imaging time point. And this really restricts some of the things that we can do. We can't watch the elegant kinetics of these radio tracers as they distribute across all the tissues and organs of the body. And what's even worse is that we go to incredible lengths to produce these exquisite radio tracers, and yet 99% of the decays that occur inside the body during the time that we're imaging are missed by the scanner because of the poor geometric collection efficiency. And of course, all these decays are also giving dose to the subject as well. So we need to do a much, much better job. And the way to do that is pretty straightforward. It's pretty obvious. We take the geometry of a conventional PET scanner and we extend the detectors to cover the entire human body. And if we do that, now we have a system that for the first time can image the kinetics of our radio tracers across the entire human body all at once. This is something actually no other imaging device can currently do. We also have much better collection efficiency for the photons being emitted from the body, so we'll be able to do studies potentially at much lower dose. And this collection efficiency goes up a lot. We're talking about factors on average of about a factor of 40 higher collection efficiency than with a regular PET scanner for imaging the whole body. So this is obvious, right? We should do this. It's clearly the right thing to do. Well, funding was not so easy. And actually, when Aruna was saying that Sam struggled to get some of his big ideas funded, it made me feel a little bit better. So just to give you a little of the history here, we started out back in February 2008 trying to get funding for this project, and it did not go well. The resubmission did not go well either. And so here's one of the reviewers' comments, and I hope that reviewer is not attending the symposium today. But they said, it's such a high cost. A large axial field of view PET scanner is certainly not economically feasible as a clinical scanner and does not even appear feasible as a research scanner. We kept going undeterred, but we tried different agencies. We went to the National Science Foundation and tried an approach there. That failed as well. Then we went back to NIH in 2011. They had a small call for what they called their provocative questions. This was the National Cancer Institute. And we did manage to get some seed funding at that time. And we also got some funding through an internal mechanism at UC Davis called the RISE mechanism. And that got us enough money to actually get some proof of concept technology development underway and some computer simulations. With all that in hand, we thought we're in a much stronger position to now go back and argue for building a prototype system. But we ran into a lot of the same barriers. We went back to the Keck Foundation again, failed again. We went out the country, went to the UK, tried there, failed again. And finally, in October 2014, we hit the jackpot with a transformative R01. Interestingly, that primarily got reviewed by people outside our own field. And that gave us a significant sum of money to actually pursue building a prototype. So about 10 years into the project, money in hand, we look very happy and moved on to actually trying to construct the system. And so, perhaps the reviewers weren't so crazy after all in terms of their reluctance, because there's some significant challenges in a system of this scale. You're talking about 500,000 detectors all synchronized within a few tens of picoseconds of each other, lots of channels of electronics, and huge amounts of data being produced from the scans. So you're easily up into the terabyte range for dynamic imaging. And of course, there's concerns about cost and reasonable concerns about cost. On the other hand, I think as you always need to push the technology forward to see what the ultimate is you can do. And then perhaps the costs will come down with time. But I think we owe it to ourselves as a field to really take this radio tracer principle and pursue it at the systems level in the human body. So here is the system. I'm going to cut out the 4 years of actually designing and building the system. It is now finished and installed at UC Davis. And this is what it looks like. So it looks pretty much like a standard PET scanner, except it's a lot longer. It's almost 2 meters in length to cover the entire human body. It also has a CT scanner on the front for anatomic registration. And the standout performance, of course, is the sensitivity value. Also has very good spatial resolution at just under 3 millimeters. So it's a very short video to show how it's built up from a single individual scintillation crystal into arrays of crystals that are read out by 4 silicon photomultipliers. That's how the light's converted into an electronic signal. That's built into a panel. There are then 24 of those panels to build a single ring unit. We then replicate that another 7 times to create a scanner that has an axial field of view of almost 2 meters. And as I mentioned, it's over 500,000 individual detectors. And this rivals the complexity of some of the high energy physics experiments at CERN, just to put in perspective how complex our medical imaging technologies have now become. So our first scan at UC Davis was just over 2 years ago. A very exciting day when we put our first subject into the scanner. Immediately got beautiful results out. This is just a standard FDG scan, 20-minute image, about an hour and a half after injection. And looking at the cross-sectional images, we're able to see a lot of rich detail here, a combination of high detection sensitivity, which means we have low noise, and good spatial resolution. So the capabilities of the system are really fourfold. It really opens up the parameter space for how we do PET studies, both clinically and in research. So first of all, we can use the very high detection sensitivity to get exquisitely high quality, low noise images, as you see on the left there. There's very rich detail, very low noise, unprecedented levels of image quality for a PET scan. But because we have so much signal, we can also use that in some other ways. So for example, we can image the whole body very quickly. So we can get a reasonable quality whole body scan in just 30 seconds. We could also use this very high detection sensitivity to dramatically reduce the dose. So on the third panel across here, you're seeing an image that has 1/20th of the regular injected dose of FDG. And again, very good image quality. It also opens up the dynamic window over which we can follow our radio tracers. As was pointed out in Anna's talk, a lot of our radio tracers are labeled with fairly short half-life isotopes so they decay away quickly. But now we have this big increase in detection sensitivity, we can follow our tracers for 3, 4, 5 more half-lives before the signal disappears into the noise. So here's an example on the far right of imaging FDG, a 2-hour half-life radio tracer, 12 hours or 6 half-lives after injection, and we still have enough signal to image. So over the 2 years we've had the scanner, well, we're using it about 50% of the time for clinical studies and about 50% of the time for research. Research, unfortunately, got quite badly impacted by the COVID pandemic, as you can imagine. But the clinical studies went on. We're almost at 1,200 clinical studies now with 3 different tracers. And then in the research arena, we have 13 active research trials currently in a range of different disease areas. And I only have time to just highlight a couple of things here. So first of all, the key advantage on the research side here is that we get the time activity curves, the distribution of a radio tracer over time in every single voxel of the human body. So we can pull out this kinetic information everywhere in the body. We can then apply our tracer kinetic models that mathematically model what happens to the tracer, how it's transported, how it's bound or metabolized and then cleared from the body. We can apply those models and we can create parametric images where now every voxel doesn't represent the uptake of the radio tracer, but it represents one of our model parameters. For example, you see here 3 different maps created from the same dynamic series of images of FDG. So we're looking on the left at the overall FDG influx, in the center at the fractional blood volume, and at the right, one of the microparameters, the glucose transport rate. And you can see that we have enough signal to noise to compute these parameters at every single voxel inside the human body. And this is a patient with metastatic kidney cancer. We can see the lesions very, very clearly. Now, following up from Anna's talk, this is the same tracer for CD8 positive T cells that she was talking about that we've been looking at on the Explorer scanner, but in patients with COVID-19. So there's a lot of interest in T cell trafficking in response to COVID-19 infection and subsequent recovery. And one of the problems with zirconium labeled tracers is that the dosimetry is not particularly favorable. You have this much longer half-life radio tracer, and so the dosimetry for zirconium-89 tends to be somewhere around 15 to 25 millisieverts per millicurie injected. So this is a lot higher than for fluorine-18 or carbon-11 tracers. On top of that, zirconium-89 only emits positrons for imaging about 23% of the time. So on a per millisievert dose basis, we're going to get 100 times more dose per detected event with zirconium than we are with fluorine-18. So if we're not going to be doing these studies in elderly cancer patients, we need to bring the dose down if we're going to use zirconium-labeled targeted agents routinely. So here's a study where we injected just 20 megabecquerels, 0.6 millicuries, and we're imaging this COVID subject 6 hours and 48 hours post-injection. And with these minuscule doses, we're still seeing very high image quality because of the excellent collection geometry of this total body scanner. So it really opens up the use of these zirconium-labeled agents in a much broader range of research subjects. And then the final project I want to quickly highlight, one that makes me believe that I'm still collaborating with Sam today. So this is an agent that was developed in Sam's lab at Stanford. It images activated T cells. It was translated to a company that Sam helped found and is run now by Aruna. And so we're just having a great time collaborating with Aruna and her team in using this tracer on the Explorer study, Explorer scanner right now to study the kinetics in normal subjects and hopefully soon in some cancer patients as well. So on the left-hand side, you see just 1 second frames watching as we inject the tracer and watching as it distributes in the body. And then in the middle panel there, a static snapshot, 50 to 60 minutes post-injection. So what I've shown you today is really the first imaging system that we have that can look at the entire human body simultaneously. And so if you combine this system with the sensitivity and specificity of our radio tracers, and the appropriate mathematical modeling of what happens to these radiotracers when they're injected into the body, this really opens up the door, I think, to study the complex systems of the human body and how they interact, and to do this in a quantitative way across the entire human body. And I think this is something that Sam would approve of. And although Sam's not physically present today, I have to say his work and his vision has given us all clear directions in many decades of work ahead. And my work certainly, and perhaps more importantly, not just the work, but the way I do my work and the way I treat my colleagues and trainees continues to be inspired from what I've learned from Sam. So Sam, we will do what we can to make you proud and realize the full potential of our molecular imaging technologies to contribute within the broader scope of better detection, diagnosis, and treatment to benefit human health. Thank you so much.
Thank you so much, Dr. Sherry, for your very clear description of that sort of time capsule of key advancements in PET imaging, closely interwoven with your beautifully described experiences with Sam. And now it's my great privilege to introduce our next speaker, Dr. Michael Phelps. He was one of Sam Gambier's primary mentors during his graduate and faculty days at UCLA, and somebody who I really remember that he spoke often of in our discussions and in our lab meetings. Dr. Phelps is now the Norton Simon Professor and Professor Emeritus at UCLA's School of Medicine. Dr. Phelps, in fact, invented PET imaging back in the early 1970s, and with colleagues, including our previous speaker Dr. Cherry, he invented the preclinical micro-PET scanners that Dr. Cherry described and that so many of us use to translate our science to the clinic. And so Dr. Phelps, he's a member of both the National Academies of Sciences, National Academy of Medicine. He also co-founded a biotech incubator and a PET imaging company. Additionally, Dr. Phelps founded the Department of Molecular and Medical Pharmacology at UCLA, as well as UCLA's Institute for Molecular Medicine and the Crump Institute for Molecular Imaging, where Dr. Gambier began his illustrious career. Please join me in welcoming Dr. Phelps.
Well, thank you very much for the introduction and for the invitation to be with you today to talk about Sam. So Sam and I lived in a loving friendship, as many of you did with Sam. Sam's family immigrated from India and mine from Ireland to a country formed by all the peoples of the world. Sam and I were far more similar than we were different, except for my boxing thing. We lived a life being students and teachers of each other with enormous natural curiosity about everything. Sam and I also live by Norton Simon saying that there's a natural curve in life. You go up, plateau, and go down. And the way to change that is to be starting new curves, and by this, to remain the state of becoming. Sam and I had a conversation in 1994 when he was an assistant professor in my department. Sam told me he was not sure that people would be interested in his work of combining biomath, physics, and nuclear medicine. I said, Sam, trust me, you have the ability, imagination, and relentless drive to not only create interest in you from nuclear medicine, but you will build a new future for it. You will be fine. Out of Sam's good heart, kind, generous, and engaging nature, Sam sought to create greatness in others. And from this, he created greatness in himself. When people would ask me, what is Sam professionally? I would say, whatever he wants to be. Now, nuclear medicine is in a state of becoming. PET and PET radiopharmaceuticals continue their high growth rate in research, commercialization, and clinical service. Excuse me. Diagnostics integrates PET molecular imaging to identify the phenotype of disease cells throughout the body to select patients for molecularly targeted radioablation of cancer cells. This will likely grow into the ablation of other disease cells. Diagnostics in a broad context of molecular imaging of phenotype disease cells integrated with different types of therapies is producing capitalization of nuclear medicine at a level never seen before. Nuclear medicine must be willing and eager to partner with other medical specialists. It must see itself as central to bringing disciplines together in diagnostics, to do things together that none could do alone. Now, diagnostics I'm going to concentrate on today is really about radioablation of cancer cells. Now, about 40% of all cancer patients receive radiation therapy by external beam approaches. But diagnostic differs dramatically from that. External beam focuses on a targeted tumor and irradiating those cells. Diagnostics uses molecular imaging to phenotype the cancer cells throughout the body for molecular targeted radioablation. The molecular probe for imaging and therapy is a small peptide, a small molecule, or an antibody labeled with a radioisotope for PET imaging and a different radioisotope to radioablate cancer cells. So both the imaging probe and the therapy probe are injected intravenously and move with the flowing blood throughout the entire body in search for cancer cells with the protein target. The protein target then provides the local molecular attachment for radioablation of the cancer cells. The molecular imaging probes are labeled with short half-life gallium or F18 or longer ones like zirconium-89 for antibodies, as Anna talked about. Molecular probes for targeted radioablation of cancer cells are labeled with long-lived radioisotopes such as lutetium-177 or actinium-225. Now, lutetium is a beta particle emitter in which 90% of the irradiation is within a 500 micron diameter sphere. Actinium-225 provides much denser irradiation because it's an alpha particle emitter in which 90% of the irradiation is within a 20 micron diameter sphere. Cancer cells are about 17 to 25 micron. So the first example in diagnostics I want to talk about is with neuroendocrine tumors. So the target protein is somatostatin receptor. The PET imaging probe is gallium dotatate. The treatment probe is lutetium-177 dotatate, and dotatate is a small peptide. So there are two questions we'll answer with the gallium dotatate image. The first one is, does the patient have the protein target? And we see from the imaging with gallium dotatate that clearly this patient does. And because of that, the patient is treated with lutetium dotatate to ablate the cancer cells. Then we use the imaging to answer the second question, have the cancer cells been ablated? And we see from the image that in this patient, the answer is yes. The second diagnostic example is a patient with castration-resistant late-stage prostate cancer who has failed all accepted treatments. So the protein target in this case is prostate-specific membrane antigen, or PSMA. The PET imaging probe is gallium PSMA, and the treatment probe is actinium PSMA. And PSMA is a small peptide. So we go back to the two questions. The first question, does the patient have the protein target? We see in the image the massive amount of metastasis. So the answer is yes. And from this level of tumors, the PSA is 3,000. So because of that, the patient received 3 treatments of actinium PSMA. We see the image that results, and the PSA is dropped to 0.3. The patient received 1 more treatment of the actinium PSMA, and we see the PSA drop even further to 0.1. And we go back to the second question, have the cancer cells been ablated? And we see from the image that the answer is yes. Now here are 2 examples of the rapid pace of recent commercialization of diagnostics. So in the neuroendocrine example, Advanced Accelerator Applications, a mid-sized French biopharmaceutical company, received FDA approval of the diagnostic gallium dotatate in 2016. Remarkably, it occurred 23 months after the pre-IND meeting, and CMS reimbursement also occurred in 2016. In 2017, Novartis acquired AAA for $3.9 billion. In January 2018, FDA approved the therapeutic lutetium dotatate. Now, also, they mentioned in the trial data that the side effects were modest and manageable. In prostate cancer, a small American company, Indocide, in October 2017, licensed the lutetium PSMA 617 for the treatment of prostate cancer from ABX. By July 2018, Indocide stock rose 600% with a market cap of $1.2 billion. FDA allowed Indocide to start their trial with lutetium PSMA 617 at phase 3, based on the published data from European academic trials, and granted them breakthrough status. In December 2018, Novartis acquired Indocide for $2.1 billion. The FDA approval for the therapeutic is expected in April 2022. Now, the last example, diagnostic example I'm going to talk about is with a probe called FAPI in a wide array of solid tumors. The therapeutic goal is, of course, to radioablate cancer cells, but in addition, to break down the stroma and the cancer-associated fibroblasts that form a barrier to the immune system and the drugs in solid tumors. The target is fibroblast activated protein, FAP, on the cancer-associated fibroblasts. Importantly, FAP is not detectable in normal adult tissue. Imaging and therapy probe is a small molecular inhibitor of FAP called FAPI. So in 2019, Sophie Biosciences licensed FAPI from the University of Heidelberg. In 2021, Sophie partnered with Novartis on the therapy side while retaining the diagnostic. So again, you see the approach illustrated in the figure below, and the protein target being FAP. Now, Simon talked about the power of dynamic studies. Here's an example of metastatic breast cancer imaging with FAPI at 10 minutes, 1 hour, and 3 hours. And you see the remarkable contrast in the image in rapidly reaching that point between the tumors and the non-tumor tissue. So the probe has extremely high specificity for the phenotype target, and you see the clearance over time. Now, these imaging studies are important in their own right, but they also provide the data for what is needed to select out the therapy probe and predetermine whether you believe it will work or not, and to optimize the protocol for treatment. So the imaging plays a critically important role for accelerating and improving the accuracy of the therapeutic trial. Now, greater than 90% of epithelial tumors have stroma-associated fibroblasts, expressing the FAP. So you see here 14 different solid tumors. Now, there's not time to go through all of them, but you can clearly see the amazing specificity and image contrast that's not only important for the imaging, but also indicative of a good therapeutic response and with low side effects. Now, this slide is my second to last slide, and there's too much information. So I just want to make 2 points. The integration of molecular imaging with therapeutics is capitalizing in nuclear medicine has never occurred before. Over $10 billion in commercial investments have occurred from 2017 to 2021 and is growing rapidly. Now, to the left, you see a number of companies in diagnostic. There's startup companies, mid-sized operating companies, and pharmaceutical companies. And it's really, and I could have added 6 more. It's really just to illustrate the dynamics of growth, and not only in commercialization, but widely throughout the world in academic programs that is occurring. And these academic programs have outlets to these many different companies to bring it to the market, and the market is responding with major investments. Now, there's an Irish saying that we should never regret what never was, but rather cherish what time we had together. And we all cherish the time we had with Sam. Thank you.
Thank you, Dr. Phelps. Thank you for your beautiful description of Sam and the heady early days of PET, and especially the emerging field of theranostics. It was incredible to hear your description of the explosive growth of imaging in medicine, almost exactly as Sam actually told us as trainees that we would eventually see. And so seeing his vision come to fruition is truly wonderful. And now it's my great honor to introduce our final speaker in this session, Dr. Catherine Ferrara. She was the founding chair of biomedical engineering at UC Davis, which is now a very large department with dozens of faculty. And several years ago, to Sam's great delight, she moved to Stanford and now is currently a professor in the Department of Radiology and the chief of MIPS, which is the molecular imaging program at Stanford that Sam had run. Dr. Ferrara is a member of the National Academy of Engineering. She's a fellow in many societies, including the American Association for the Advancement of Science. And she and her lab have received many, many awards through the years for their work in image-guided drug and gene delivery, nanoparticle design, and a lot of other areas. And recently, her labs focus more on strategies including immunotherapy, immunoimaging, and nanovaccines. And I can say that in my several discussions with Dr. Ferrara, I've always been very impressed by her clarity of thought and her articulation of very provocative scientific questions, as I'm sure you'll see. So please join me in welcoming Dr. Ferrara.
Thank you so much. Hopefully you can see my slides. I have the challenge of describing Sam's lasting impact on the molecular imaging program at Stanford. I think this is one of his major impacts locally and nationally and internationally. And I want to thank the organizers and for giving me the opportunity, and also I'll call out to the exciting news from Dean Miner and Gary Gold this morning about the announcement of the additional cyclotron, which will be a huge impact on our program and on Stanford. So the molecular imaging program at Stanford is an interdisciplinary program that bridges between radiology and other departments on campus. There are 36 primary faculty and about 230 participants. The founding goals that Sam had elucidated were to bring together scientists and physicians to fundamentally change how biological research is performed with cells in the intact environment, and also to develop new ways to diagnose and treat diseases. So those in the red bars here, in the red squares here, are relatively new members of our growing program. I wanted to start my introduction by talking a little bit about the journey and Sam's tenure at Stanford. As a number of people have stated, Sam came to Stanford in 2003, and the formal MIPS program was established at that time. He later, in 2011, became the chair of radiology at Stanford. There were a number of important developments for the program here that occurred. Maybe most important was the opening of the cyclotron and radiochemistry facility in 2005. This and Sam's leadership led to a number of different initiatives at Stanford, including the Canary Foundation, the in vivo cell and molecular imaging centers, the Stanford Center of Nanotechnology Excellence, and the Neuromolecular Imaging Program. It also led to the establishment of a number of other facilities, including multiple small animal imaging facilities and the nuclear medicine clinic. We have the development or the incorporation of PET-MR as a clinical modality, MR-focused ultrasound, and more recently in the Department of Radiation Oncology, also biology-guided radiotherapy. So many important developments over this period of time. We think that also sees Sam's vision in many of the clinically translated devices that came from his work and inspired others as well. So I'm going to break my talk into talking about devices as well as radiopharmaceuticals. So thinking about devices first. Sam was definitely a pioneer in many imaging devices for endoscopy and intraoperative imaging, including both optical and gamma camera-based techniques. More recently, he also developed instruments for combining ultrasound and photoacoustics that were translated, and more recently as well, the smart toilet that has been an important and interesting development that has the potential to advance the precision health initiatives. Now, he also had developed a number, as people have stated, a number of PET tracers, and the MIPS faculty have also within this period developed a number of interesting tracers. Sam is well known for the reporter gene imaging, and I'm going to talk a little bit more about that later. But also the faculty and Sam's lab have developed tumor targeting radio tracers, including the Naughton-based, RGD-based, and from the Rao lab, the CSNAT-based tracers. The Biswal lab also has developed radio tracers for pain. Sam's lab has been very involved in developing tracers for immune imaging, including ARG, as has been discussed, and also immune activation radio tracers. And finally, I just wanted to highlight the work on looking at tumor metabolism using F18 DASA, and I'll come back to this in a bit as well. So this just gives you a sense of some of the activity in the molecular imaging program at Stanford. The graph on the left is a graph that was compiled by recent collaborative papers between our basic science and clinical members, and just to demonstrate that really Sam's legacy is a very interconnected and outstanding team of scientists that range through many different disciplines, through many different departments, and many different research facilities as well. So on a more personal level, I had a number of really amazing opportunities to interact with Sam. In 2011 and 12, Sam was able to help me to arrange for treatment for my father at Stanford, something that was really an amazing thing for him. I was just a colleague at UC Davis at the time, and he was incredibly generous to help us. I later, from 2016 to 17, was a visiting scholar in his laboratory and moved to Stanford in 2018 as a professor of radiology, and more recently became the division chief of the molecular imaging program at Stanford. So I'd like to give you a few specific examples, both of devices and of radioisotopes. Some of the examples of devices include ultrasound. So in the heart of my laboratory and many of the people who work in my laboratory is ultrasound. And we've known forever that the lateral resolution of ultrasound is inversely proportional to the size of the transducer that we could utilize to image. But we were pretty limited in our ability to make that larger. So recently we've had the ability to engineer transducers and imaging systems that can take us further. Now we're in the process of creating many of these unique devices, and the themes are we now have the ability to utilize thousands of channels for ultrasound information to create transducers with many thousands of elements, and to do all this with thousands of frames per second. So many of these devices are now becoming real as we, with our colleagues at USC, create application-specific integrated circuits and embed them within transducers. And we're looking at applications including the liver, breast cancer, and our stretch goal is to think about, can we image the abdomen of a child in a time frame on the order of, say, a second. So to do that, we need about 50,000 elements, and this is kind of driving our developments at the moment. But just to show you what this can do, if we compare a commercial array to what we can engineer, we can, with thousands of frames per second, we can engineer a wider field of view. And you can see from the very fine speckle that we can improve the spatial resolution. On the right-hand side, you also can see the greatly improved spatial resolution that can be achieved with a larger number of elements. And then we also have the ability to, there we go. We also have the ability to scan such arrays in real time with our very high frame rate. And we've taken this into human studies, and an example of commercial imaging compared with an extended field of view and enhanced resolution is shown in liver imaging below. And a further application of this technology is in imaging the breast for breast cancer. We've created sets of arrays, and you can observe the spatial resolution on the lower left. We can achieve images that look a lot like X-ray CT with just ultrasound and with great resolution. The image on the lower right is an image from a flow phantom in which you can observe flow that's moving through a tube in 360 degrees. And we can sensitively detect that in any angle. We also can create functional images. So we know that cancers often shadow ultrasound, but if we have a lesion in the center of an image, we can simultaneously acquire the view from each individual angle and see the shadow coming from ultrasound. We can process those data and create a shadowless image that quantifies the functional properties of that lesion in the center. And most exciting, we can do all this in real time. So we can, for the first time, really at thousands of frames per second, we can create real-time tomographic images. And I think that this is the sort of thing that Sam would be excited to see a very different technology and a leap in what we can actually visualize, particularly in real time. Now, I'd like to highlight one other device or set of devices coming out of the molecular imaging program at Stanford, and that's the work of Craig Levin, who's developing a set of positron emission tomography devices, including a PET insert that can be placed in any MR system, improved spatial resolution systems, including time of flight systems that achieve on the order of 100 picosecond coincidence time resolution. Craig is creating a couple of different technologies for 3D position sensitive scintillation devices and applying them both in clinical scanners and in small animal scanners. And finally, to further push the spatial resolution, he's investigating the modulation of optical properties of devices with the goal of achieving another tenfold improvement in spatial resolution. So as other examples of ongoing activities within MIPS, I'd like to look at a few examples of PET imaging as well. And first, just to Andre gave a great overview of, from a nuclear medicine standpoint, that there have been quite a number of unique radiotracers and just quite a large amount of activity within the program in the cyclotron research facility that's led by Ben Shen. But I also wanted to just highlight the activity in a given month and Ben's team, how amazing they are and how amazing the opportunity will be to have a second cyclotron from, in addition to producing FDG, they are on a typical day, if you look at the pink output, they are creating multiple unique isotopes that are finding their way to patients as well. Now, in my own lab, we've worked on the PET side from labeling biomaterials of various kinds for PET imaging over a number of years. So we've had projects from small molecules to peptides and dendrimers to NOOs, diabodies, and micelles and liposomes, lots of unique kinds of technologies. More recently, we've become very interested in adeno-associated viruses, and I'll tell you a little bit more about that, being able to label them for PET imaging. Now, we became interested in these devices, and I had the opportunity to talk with Sam about using PET imaging to be able to track these adeno-associated viruses over time. And we developed a collaborative project using PET. From our lab standpoint, Jay So has been leading this work, and he has been developing the methods to add a copper label, a radioactive label, so that we could track the organ distribution of gene therapy over time. He has also added an optical tracer so that we can track with very high resolution in preclinical studies the distribution of the adeno-associated viruses over time. And we collaborated with Sam to go beyond just traditional fluorescent proteins, but go further to look at PET reporter proteins, and in particular to look at a couple of the PET reporter genes that Sam had developed. Here I'm highlighting the work of Tom Haywood, who developed one of these. So adeno-associated viruses are non-replicating viruses. They can contain single-stranded DNA, relatively small quantities, but they're relatively small, which is great for making it into small regions and making it across the blood-brain barrier. They allow and facilitate cell-specific gene therapy because they can have cell-specific promoters as well as a unique capsid. We've been collaborating with Viviana Gradinaru at Caltech, among others, to look at unique capsids. And this is one that Viviana had developed called PHPEB that can transfect the entire brain. These have the promise to treat very difficult brain diseases that potentially really don't have other options. There are 2 approved products, but this is another area where the science is rapidly expanding. And if you were to look at commercial clinical trials, even in 2019, you would see the substantial growth of new clinical trials in the adeno-associated virus world. So our work was to develop labels to be able to watch adeno-associated viruses in picomole quantities as they move through the body. And Jay developed a dendrimer strategy that allows us to chelate multiple radioactive molecules onto a single dendrimer and attach only 1 or 2 dendrimers, tiny little things, to the outside of a virus so that we could track it. We've found that that can work really well, and positron emission tomography can give us a great view of the opportunities for gene therapy. Now here we're just watching where the virus goes after it's been administered in the tail vein of a mouse. And if we compare a traditional adeno-associated virus, such as AAV9, to a new adeno-associated virus, such as PHPEB, you can observe 20 or 30% of the injected dose per cubic centimeter makes it into the brain, which is really a remarkable amount of delivery for systemic administration. So we've then been working on pairing with Sam's technology. So Sam's lab with Corinne and Tom have developed a PET reporter gene that uses the PET reporter probe F18 DASA23, which binds to a protein called PKM2 in order to create an image. Now, this reporter probe was first developed to image cancer, but we're using it here to take a virus that can cause cells to express PKM2 and to be able to determine where in the body the reporter gene is actually being expressed. So where in the body do we have effective gene therapy that's happening? And so we've now demonstrated that even with systemic administration of a novel adeno-associated virus, we can observe that a significant amount of protein is being expressed as a result of that injection. And this increases over time. So we're able to see the unique features even at 1 week. But going further at, say, 3 weeks after injection, we see that the amount of protein that's being created by this gene therapy is increasing over time. So it's very encouraging for the use of reporter gene imaging to preclinically and potentially clinically to track gene therapy. We have many candidate AAVs directed to the brain or selected organs that we're evaluating in this project. Just one other example, we were also looking at the feasibility of using PET reporter gene imaging for looking at where SARS-CoV-2 goes and where it's expressed. So here we have a pseudovirus that has the spike protein. We have a humanized mouse model that expresses the ACE2 receptor. And we're able to administer the virus intranasally to a mouse and demonstrate that we can observe the expression of the reporter gene that was encoded within the mouse. So we're now screening therapeutics that can block infection. Yeah, and finally, just a few other examples of other developments in MIPS radiotracers from Michelle James's lab and Israth alum as demonstrating the further use of ARA-G in looking at graft versus host disease. And another example of the use of Michelle James technology to look at microglial activation in patients with Parkinson's disease. This is an example from Corinne BNA. And here we're looking at DASA23, and we're looking at tumor metabolism in patients with glioblastoma or glioma. And finally, in my own lab, we're taking forward a probe for CD40, which is an immune agonist that's used in pancreatic cancer. I'd just like to highlight Andre's work in all of these translational activities that are allowing some of the things that are developed in MIPS and in nuclear medicine to be translated efficiently. So in summary, I'd like to just express our tremendous thanks for Sam and to express from the molecular imaging program at Stanford that we continue to thrive because of Sam's vision. Also we're enormously excited about the facilities that we have the opportunity to use, but also the solid target cyclotron that's coming. And also finally, my own funding sources and members of my laboratory as well. So thank you so much.
Thank you. Thank you so much, Dr. Ferrara, for that beautiful overview of recent developments in hardware and applications in molecular imaging, and the highlights of the amazing work really still going on across MIPS. And thank you for as well for also working with and now spending time mentoring a number of former Gambier trainees. And I'd also like to take this time to thank all the speakers in our molecular imaging session this morning. Your warmth and intimate sentiments towards Sam really shone through your stories, and your revolutionary science and engineering, I think, are emblematic of our field and really speak to your leadership of it. And so now that the speaking session is closed, I'm going to open it up now for the question and answer session. We're a little bit over time, but we'll still wrap up the Q&A session on time at 11:15. And so as we sort through your questions, I'll just start with one. This is to any of the speakers, any and all of the speakers, which emerging molecular imaging modality do you believe has the highest potential for basic science and translation in the coming years?
Well, I think, certainly the diagnostics, is demonstrated by amazing science, incredible, actually remarkable imaging of the phenotypes and therapeutic responses. The approvals occurred very quickly because the results were so impressive. So I think now in the broader context is really integrating molecular imaging phenotypes with all therapies. But
Thank you. And Michelle, do you have a question from the audience?
I do. I have one for Dr. Cherry, and the question reads, since dynamic imaging takes a series of whole body images for several time points, does it require taking a new set of CT images for attenuation correction each time at every time point? Or is there another way to do PET attenuation correction without repeating CT?
Really good question. So for the short-lived traces, of course, the patient's on the bed the whole time and we get the entire dynamic time series. So as long as they don't move, then the CT is in registration. But the zirconium studies that I've been showing, where we're getting the patient back on the bed multiple time points, that yes, we need to reacquire the CT scan. So that brings up dosimetry for the CT scan, and that's an area we've been actively working in using convolutional neural networks to reduce the noise levels of the CT. So we can get the CT dose down very low if all we need the CT for is for rough anatomic localization and for attenuation correction of the PET study. And then there are some other opportunities in the future. This total body scanner has a lot of slightly radioactive lutetium inside of its detectors that are emitting radiation. And theoretically, you could use that background radiation as a transmission source to get the CT scan or the attenuation correction scan while you're doing the emission scan. So we have a lot of simulation work going on that right now, but it's not at the point yet ready to be implemented.
Bryan, did you want me to read another question? Or?
I can go ahead. So Dr. Ferrara, would you be able to apply AAV tracking technology in liposome mRNA vaccine delivery systems for real-time imaging of biodistribution and gene therapy efficacy?
You're asking, could we apply reporter gene imaging to non-viral gene delivery methods? Is that correct?
Correct.
Correct. Sure. I think there are definitely opportunities to apply similar both, and certainly we have tracked non-viral delivery vehicles by tagging them, and there is the opportunity to use reporter gene imaging similarly to image the resulting expression.
Thank you.
Excellent. And now we have two quick questions for Dr. Wu. The first is there any advantage of CD8 immunoimaging over CD4? And the second has to do with whether you've tested your method in humanized PDX mice to assess activated T cells.
Yeah, so you certainly can image CD8 or CD4. CD8, it depends on the biological question you're asking. And with CD8, it's much more straightforward because the CD8 expressing cells are by and large the cytotoxic T cells. So, that gives you a very straightforward answer. But CD4 cells are more complicated. It includes helper subsets, Th1, Th2, Th17, but it also includes regulatory subsets. So you have a mix of opposing activities, and that can complicate the interpretation of the signal. So I think you really need to understand the underlying biology, and there certainly are instances where CD4 could be very informative, as long as it's a situation where you're just looking at Tregs or just looking at different helper subsets. So, we can't yet image FOXP3 which is nuclear protein. So that I think would be one of the holy grails. Can we image FOXP3 in the nucleus and really look at those Tregs? And no, we haven't had the opportunity yet to look at, my lab hasn't been doing the PDX models. We're working more with syngeneic models and mouse models, but thank you for those questions.
Yeah. Dr. Wu, you mentioned that multicolor technologies are needed. How do you really see that emerging in coming years?
Well, I'm very pet centric, but I know, for example, Craig Levin and others are trying to work on ways to distinguish the different pet radionuclides. I think you could also think about pet and SPECT. You know, the sensitivity of SPECT is lower, but the advantage is you do get much cleaner, you know, potential for energy discrimination. You can also play games with PET where you do different half-life isotopes and do an early scan or a late one. I think my very simple approach, which is not really multiplex imaging, would be to do rapid sequential imaging using, for example, F18 labeled diabodies or other small molecular peptide probes. So there are advances, hopefully, that we can make both on the radio tracer side as well as on the instrumentation side. I think there's still work to be done, because I do think that it's hard to capture all the information that we need to know, you know, out of just one scan with one tracer.
Absolutely.
Yes, and there's one more question for Dr. Cherry, and it's from Weibo Kai. He said, Simon, excellent talk as always. What are the different ways to improve the time resolution of PET detectors? Some scanners have 400 picoseconds resolution, some are close to 200. What do you think will be the time resolution in 5 or 10 years?
Great, Chris. Great question, Weibo. Good to hear from you. So I think that's the next big frontier for PET, and where we'd like to get to is sort of the 20 to 30 picosecond range, because then we will be able to directly localize each emission event in 3 dimensions. We will not need to use image reconstruction anymore. So we're getting close in the benchtop experimental setting. People are getting down to 30, 40, 50, 60 picoseconds with different approaches. I personally believe scintillation is probably going to be too slow a mechanism to do this. So I think prompt luminescence that comes, for example, from Cherenkov radiation may be a better way to go if we're going to get there, but those signals are very faint, so you need really sensitive photodetectors, very, very good electronics if you're going to pick that up. So I don't know how long it's going to take us to get there. I will be bold and say we will get there, and we will be there in commercial clinical systems with, you know, time of flight at the levels where we do not need image reconstruction anymore. But I'm not going to tell you when, because I really don't know.
Excellent. We're looking forward to that.
Thank you. And to all the panelists, which molecular imaging technology or application that Sam developed do you believe is going to be ultimately his most long-lasting or impactful? I know it's hard to choose just one.
What do you think?
I might be biased toward the nano side, but I think it's hard to say, because his nuclear medicine images, his nuclear medicine approaches are so far way more advanced than many of his other technologies, and so his immunoimaging seems to have the potential to really change how immunotherapy is operating, and I think that could change how immunotherapy is clinically delivered, and so it seems to me that currently that's the biggest way forward. But I think some of his early ideas, the toilet and combining technologies, could ultimately be way longer lasting. So That's how I would currently see it.
We're still working on the tricorder, right? I mean, that was Sam's original vision. He was a great Star Trek fan, and he just wanted that tricorder scanner that you could just scan the person and see what was right and what was wrong with them.
You're absolutely right. I talked about that a lot in lab meetings. Yeah.
You know, I think one thing that's important to realize is that when we have clinical success, that produces funding for the basic sciences. So, you know, it's important that we build a principled and fundamental science for what we do, but the clinical success helps that to be funded. And, you know, it's amazing to me when you look at diagnostics, how quickly it's grown by the quality of the result. You know, and the investments are way beyond the 10 billion I mentioned, but there's been a pathway created from labs all over the world to do the science. And they had many commercial outlets of small companies, mid-sized, pharma. I mean, it's really quite remarkable. You know, in COVID, we watched for the first time the largest number of people throughout the world to work on one problem. And they were amazing. And, you know, Sam was a master of bringing people together. We all know that. And to achieve these things, from the basic science to the clinical research to the clinical outcomes, you have to bring people of many different disciplines together and create this new world. That's what he did so well.
Thank you. And I think that's a great way to close this session. Thank you so much, Dr. Phelps, and thank you all, panelists. We really appreciate that.
Thank you.
Thank you.
Thank you so much. Yeah, thanks so much.
Good to see all of you.
Hope to see you in person next year.
Yes.